Hello, my name is Sam. I'm one of the renal registrars from the Great Ormond Street Hospital. Today I will talk about assessment of the fluid status in renal patients. In particular, I will talk about nephrotic patients. When we know that 60% of our weight is water, and in the small babies, even up to 80% of their weight is water, then it's worth understanding what's happening with these fluids and what's the distribution of these fluids. For easy calculation, I will stick to 60% of the weight is water, and I will take the example, for example, a child who is 10 kilograms, so 6 liters or 6 kilograms of his weight is water, out of which 40% of that is within the cells, and 20% outside the cells, extracellular, and those extracellular distributed as 5% within the blood vessels, intravascular, and 15% extravascular. In nephrotic patients, it's very, very important to understand what's happening with the pathophysiology and how and what should we do with the fluid management of these patients. So, for example, if we have got a child who is 5 years old, first presentation of nephrotic syndrome, and this child coming puffy, swollen feet, and having maybe ascites, the problem with those ones is that we don't know what was the weight before that. And the basic assessment and the essential assessment for those ones, taking very careful history. How did it happen? Whether there was any previous illness? Over how many days this child started to become swollen and edematous? And how much this child is drinking? How much he is weeing? And on our clinical examination, the first thing to assess on these children is what's the weight and what's the blood pressure. Is this child cool peripherally? How is the heart rate? What's the capillary refill time? This child with a nephrotic syndrome, what happens is that they are losing protein in the urine. Subsequently, they don't have enough oncotic pressure inside the blood vessels to retain the fluids intravascularly. So subsequently, they lose these fluids into the interstitial fluids, plus losing these fluids as well into the peritoneum, which we call third spacing loss. So they become intravascularly depleted in many of them. My talk is not going to be about the steroids management, but more about the fluid management. Here, we have to be very, very careful with those ones, because their weight, despite of going up and higher than their usual, they are still intravascularly depleted, and they are at the risk of thrombosis as well as acute kidney injury. So, when we are assessing these patients on a daily basis, we have to make sure that we are weighing them twice daily, and we are taking regular measurements of the blood pressure. The best way of measuring blood pressure is the manual way, using a Doppler and using the largest cuff on their arms, and also looking very, very carefully at the heart rate and the cap refill time, and assessing them frequently how cooled they are peripherally. So when we see these patients, assessing just twice daily, measuring the weight, having strict input-output, we can't miss the urine of these patients, because we need to really very carefully know how much they are drinking and how much they are weeing. And now will come the question of how much fluids are they allowed. The main problem in the nephrotic patients is to restrict the salts. Yes, there is a figure of 1 liter if they are more than 5 years, or 750 if they are less than, but frequently the children don't stick to that, and they sometimes drink more, but we need to calculate how much they are drinking. We have to also, again, just keep a close eye on how much they are drinking, but as I mentioned, the main thing is the restriction of the salts in their diet, because that's the main item which will retain the fluids in their body. So at the time when we will start seeing these patients passing a lot of urine, and the weight is getting less and less. So this reflects that these patients started to shift the fluids from the extracellular fluids from the extracellular compartment into the intravascular compartment, or from the interstitial to the intravascular compartment. Another question frequently in those patients: when to give albumin? There is no certain figure below which, for example, say less than 20 gram per liter of albumin, we are going to give albumin, because the challenge is some children, say for example, with a serum albumin of 21, but they have ascites, they have significant intravascular depletion, they have significant edema lower limbs, and they're tachycardic, and those ones will require albumin, not without giving them furosemide. Some other children, they will tolerate serum albumin, say for example of 17, 18, without losing a lot of fluid into the interstitial fluids, into the interstitial space. So, and when we are giving the albumin in a GTH hospital, the best way to give it is to give 4.5%. We have to assess the patient before, we have to assess the patient after, and we have to assess the patient in between. Because giving furosemide in a child with a nephrotic syndrome who is intravascularly depleted, this can